criteria aren't really a surprise to anybody in the field. There have been variations on them that people have used over time, although this large working group went through the literature and spent countless hours streamlining these criteria. But at the core of these criteria are that there has to be a clinical event that is consistent with what we know about MOGAD, and that would either be optic neuritis, myelitis, ADEM, which we see in children. We see brainstem syndromes, and we may see cortical events and encephalitis events with seizures. And so first and foremost, you have to have an event that's consistent. And ideally, you have a high quality result from a cell-based antibody test. Ideally, it's going to be a live assay, but a lot of parts of the world only have access to fixed assays. And also, we're not quite sure what the meaning of the antibody presence in CSF tells us. We're still working through that. And if you don't quite meet these criteria, we have supporting clinical and MRI features. And groups have been trying to sort of validate these criteria against kind of what we accept as our current gold standards. And they end up being fairly meaningful and being valid with other things we know about MOGAD. And so the criteria really don't pose a great surprise to anybody in the field, but they do simplify matters, and they behoove us to really try to clean up our antibody assays and use ideal antibody assays and learn more about what antibodies in CSF do and don't tell us. But really what they're going to do is they're also going to, for research purposes, allow us to populate trials with patients that truly have this disease. Partly, I think a lot of our NMO trials in previous years probably contained a lot of MOGAD patients, but we didn't yet know that.